Hello, everyone. My name is Shabir Musa. I'm a family physician in Soweto, and I thought I would we'd start. I have a little bit of a challenge. I have to find our speaker, I think, amidst all the um, just see that our panelists join. So welcome. Welcome to all of you. Ah, there we go. So, welcome, Kwame. Can you hear us? I just need to unmute you and allow you to speak. Hi, Kwame. Good. Would you want to show your video as well?
Yes, I'll show slides.
Okay. You can put your video on as well so people can see you. I think they'd probably appreciate that if you can be live. I'll switch my video on. So welcome to everyone. Thank you all for joining us. I think that it's great that we have Kwame on board. I was really afraid that we'd be only with me, and I'm kind of boring right now.
Yeah, I need to adjust the audio slightly.
Would you like me to make it louder? Are you hearing me well enough? Kwame, are you able to hear me all right?
Just a second.
Okay.
Right, this is better.
All right, good. So I'm just sharing a few slides. That's just to give you an orientation. I think welcome. I'm going to leave the rest to Kwame. Kwame, you can basically go forward, present. I think what's happening in Ghana. I think this series is basically about us being able to share stories of what is happening in primary care. I think firstly, what's going on in our country in the sort of bigger picture of Africa. And then if you can share what is the response by each government, what are they doing in terms of overall health system, and then from yourself particularly, what is going on in primary health care, what are the efforts, what are the challenges. So I'm sure you're going to do a great job. Thank you very much. And we'd also like to encourage all of you who are listening, please try to put in some questions. We can then go through some questions. The webinar will go for 90 minutes. And most of that will be actually responses and to your questions, and maybe even one or two of you who'd like to share. So if you feel you'd like to share a little bit of what's going on in your country, feel free, just raise your hand and we will try and address that after Kwame is presented. Kwame, over to you. Do you mind just quickly telling a little bit about yourself? I kind of jumped in. I'm also the president of Wonka Africa. Kwame, Dr. Aisi Boateng is the chair of AfriOne, which you might say is which is the Wonka of the future. So let me hand over to Kwame. Kwame, you can just share a little bit more about yourself and then take it from there.
Yeah, so I'm Nana Kwame Aisi Boateng, and I'm a family physician. I work in the University Hospital, KNUST in Kumasi. I finished my training as a family physician, was certified in 2018, and I'm the current chair of AfriOne, which is a young doctors movement for Wonka Africa. Currently, my role in COVID-19 is because I'm the head of the infectious disease unit at the University Hospital, KNUST, and we've been quite involved in COVID-19 management, detection of cases, management of cases, and we support the government in its efforts to fight COVID-19 in Ghana. And I count it a privilege that I've been called upon to share our experience. And my experience is mainly based on what we are doing at the University Hospital and what I know is being done in other parts of Ghana. So if I can confirm, my slides showing?
Yes.
Prof. Sabrel. Okay, you have access to
Going
the slide.
very well. Yes,
Very
you're
well.
going pretty well. Thank you very much. I've just switched off your video because I think your video is not working, but it's fine. Go ahead.
But you can see the slides, right?
Yes, we can see slides. No problem. Just
Very
I
good.
think your video on that side slightly challenged, but don't worry. Go
Thank
ahead.
you. Thank
Good.
you. Right. So I do this presentation paying tribute to a legend by name Professor Jacob Plangerul. He was my teacher. He taught me in medical school. He was a mentor and then a role model. Unfortunately, he passed on 10th April 2020 in a fight against COVID-19. Prof. Plangerul was the rector of the Ghana College of Physicians and Surgeons and the former president of Ghana Medical Association. He was a great person and I pay tribute to him. We all know that coronavirus or corona SARS-2 was first detected in Wuhan, and it was reported in the WHO country office on 31st December 2019. WHO declared it as of public health emergency, which was of international concern on 30th January 2020. Then it was declared a pandemic on 11th March 2020. This morning, when I checked the current data on COVID-19, 2.6 million people have been infected with coronavirus. We've had more than 180,000 deaths, which bring it to almost 7% case fatality rate. And more than 700 people have recovered globally. This is a global picture from WHO. For Ghana, our first cases were detected on and were confirmed on 12 March 2020, and these were imported cases. So on 21st March, the government of Ghana closed all our borders, and then all persons who came into Ghana were put on mandatory quarantine, and an enhanced surveillance were conducted for all travelers. And the president made a profound statement that we know how to bring the economy back to life. What we do not know is how to bring people back to life. Then on 30th March, at the time we had confirmed 137 cases in Ghana, 4 deaths, the government imposed a partial lockdown in 2 main areas which had high prevalence of coronavirus. That was in Accra and Kumasi. So the partial lockdown gave exceptions to people who have to go to hospital or health workers and other security personnel and all that. That's why it was called a partial lockdown. It didn't cover the whole nation, but these 2 main cities and municipalities in Ghana had a partial lockdown. Initially, it was a 2-week partial lockdown, but after 2 weeks, the government of Ghana extended it for an additional week. And during that 2-week period, the government came up with some incentives for frontline health workers. Some of the incentives included having tax waivers for 3 months from April to June for frontliners. Frontliners also enjoying 50% of their basic salary as an additional allowance. And then also came up with some social packages for Ghanaians. So free water bill for some section of Ghanaians. And then there were some Ghanaians who depend on your level of usage of electricity. We're also giving rebate in terms of paying for electricity. So all these were done to relieve some hardships on Ghanaians and also to motivate frontliners. Another thing the government came up with was also an special insurance package for frontliners. So all these incentives were announced by the president during the lockdown period. Now, after the 3-week lockdown, the president on 19th April came back to the nation and then gave us these statistics. That was as at 19th April. As at 19th April, 68,591 cases had been, patients had been tested. I mean, people who were suspected to be having COVID-19 were tested. The total number who tested negative was 67,549, which showed 98.5% negativity rate. For those who were positive, out of the 68,591 were 1,042, which showed that our positive rate was 1.5%. 99 patients as at that time had recovered, which showed 9.5% recovery rate. 9 patients had died, and all these 9 were patients who were reportedly having underlying medical conditions. So our case fatality rate in Ghana as at 19th April, announced by the president, was 0.9%. He gave a breakdown of the people who had been tested. So in Ghana, we have what we call the routine surveillance. The routine surveillance is what is happening in various hospitals or various health centers on people who we suspect to have COVID-19 who are tested. So routine surveillance, 16,817 have been tested. For enhanced contact tracing, and these were people who had come into Ghana early March and had slipped through the borders. And so the president asked that the disease control officers and community workers go into the communities and then take their samples and test them. Those were 49,699. For others who were on mandatory quarantine, that's those who had come into the country, who had traveled into the country and were on mandatory quarantine, 2,022 were tested. Out of this, then you see that for routine surveillance, the positivity rate was 2.27%, enhanced contact tracing was 1.09%, mandatory quarantine was 5.59%. So still giving us positivity rate of 1.52%. So on the basis of this, and with the fact that this enhanced contact tracing was being done and routine surveillance were being conducted and more facilities were being equipped to be able to conduct testing, the president of Ghana then lifted the partial lockdown with effect from last Monday, which was 20th April. So the partial lockdown was lifted from in the cities of Kumasi, Greater Kumasi and Greater Accra region. And in a speech, the president encouraged wearing of masks and for everybody to continue practicing social distancing and then perform hand hygiene. And then also directed that all confirmed cases, instead of keeping them in homes, should rather be kept in isolation centers, which may be a treatment center or especially designated areas, which may not necessarily be a hospital setting, for those people to be confined and then given medications or monitored and ensure that they are not mixing with the rest of the population. For this morning, the current confirmed number of cases of COVID-19 in Ghana stands at 1,154. We still have 9 deaths. Majority of the cases, that majority of the 1,154 are patients who have either mild symptoms or are asymptomatic. For Ghana, we have 3 main testing centers for COVID-19. And basically what we do is the real-time PCR testing. And we take samples, either sputum samples, nasopharyngeal swabs or oropharyngeal swabs. And currently we're also doing nasopharyngeal washout. The 2 centers are mainly in Accra and Kumasi. That's the Noguchi Memorial Institute for Medical Research, and then the Kumasi Center for Collaborative Research in Tropical Medicine in Kumasi, KNUST, and then the National Public Health Reference Laboratory. The government is taking steps to decentralize the testing so that it can be done in other parts of the country, that's the northern part, the eastern, and other parts of the country, and equipping other laboratories to be able to do testing. Now, in terms of policies and guidelines, the Ghana Health Service has come out with policies and guidelines to guide all of us in what we do. So a very comprehensive document called the Case Management Protocol, which has guidelines on how to manage mild, moderate, and severe cases, have been launched. We also have guidelines for home care for patients who are at home and need care. There are guidelines for isolation. We have definitions for contacts and contact tracing. There's a comprehensive guideline for infection prevention and control. And all these have been made available to health workers to access. The current definition for a case in Ghana is that for a suspected case, that's a person with fever greater than or equal to 38 degrees Celsius, or a history of fever and respiratory tract symptoms in the last 14 days before onset of symptoms, or has had close contact with a person under investigation or confirmed for COVID-19. So once a person reports and then falls into this case definition, then a sample is taken. But when the sample is taken, it comes out as confirmed positive. These are some of the treatment centers that are available in Ghana. Most of them are situated in Accra. So the first two hospitals, which is Ghana East Hospital and then the Bank of Ghana Hospital, have been dedicated solely for management of COVID-19 cases. So those two hospitals are just for COVID-19 cases. The other hospitals perform other duties or take care of other patients, but then they are involved in treatment. That's the University of Ghana Medical Center, the Kolobu Teaching Hospital, the Konfanochi Teaching Hospital, Kumasi South Hospital, and KNUST Hospital, where I am, where we have an isolation ward. But we haven't yet admitted any patient to our ward. But apart from these that I have listed, in other parts of the country, like in health centers, in some communities where you have physician assistants, some patients are being taken care of within those communities. So that emphasizes what the role of primary care professionals as well in areas where we don't have big hospitals with big facilities. And then apart from the treatment centers, we also have the isolation centers. And some of these ones have been, they are like guest houses or hotels where patients who have tested positive for COVID-19 are in isolation, but they are not hospital facilities as such. So such patients are kept there to be monitored and prevent them from going out and mixing up with the general population. And if there are any problems with them, there are nurses and some doctors on call to respond if they have to be attended to immediately. So I zoom in on where I work, which is the University Hospital, the KNUST Hospital. The picture we see on the left side is how our hospital entrance looked like before, about 2 months ago, before we had COVID-19 being detected in Ghana. So that was the main entrance. And then we put up 2 tents. The first tent is a pre-triage area. So we made it such that any person entering the hospital coming through the OPD will go through the pre-triage area. The pre-triage area is used to screen anybody coming in to find out if you have symptoms of any respiratory tract symptoms, any travel history, or come into contact with an individual who may be suspected or confirmed COVID-19. And once we pick it at that stage, at the pre-triage area, that a person has suspicion of COVID-19, then the person is moved to the second tent, which is the holding area. Then in the holding area, samples are taken, and then the patient is held until the results come in. Then behind the holding area, we've created a dolphin area for our health professionals who go in to take the samples to DOF. So they come out and then they remove the PPEs at the dolphin area, which is close to the holding area. We've taken our staff through training in wearing and removal of PPEs, and all categories of staff have been trained in this regard. Doctors, nurses, we have cleaners in the hospital, ambulance drivers, and everyone has been trained in terms of being able to respond to any suspected case or any confirmed case of COVID-19. We also conduct home visits. So home visits are for one, if we get a call that somebody has symptoms and wish to test for COVID-19, we do not encourage them to come to the hospital for testing. We rather go there and then take the samples. And then also, we also have some confirmed cases who are asymptomatic and are at home. So we do home visits to take care of them, monitor them, check their vitals, take their samples for repeat testing. And these are pictures of our home visits. Now, some of the challenges with these home visits are, in Ghana, in other parts of Africa, poor road networks, poor accessibility to areas is one major challenge that we face. So one of the patients, we're going to the home, center as a GPS location, we follow the GPS, but unfortunately, as we follow the GPS, and we go to a place where it was immotorable. Finally, when we found our way to the house, the problem was with how to get the ambulance or the car into the house. These are some challenges that I'm sure can be identified in other parts of Africa. Other challenges that we are encountering are that some patients test positive for COVID-19. We show them evidence of their test results, but are in denial. So they doubt that they have the infection. Some of them is personal denial. The patients themselves doubt it. Other times, there are family members who doubt that the member of the family has it. And it becomes more difficult, or they tend to doubt it more when one person is infected, but other contacts within the house are negative. So denial is one thing that we constantly have to be counseling them to be able to accept the results. Another part is stigmatization. So this is something that we're also grappling with in terms of being able to help them overcome stigma within their community, stigma within their families, and all that. And then there's psychological trauma. So we have enlisted the help of clinical psychologists to provide counseling and then psychosocial support for some of the patients who test positive. And sometimes even the patients who come in and are in holding area or in quarantine, they also go through counseling to help them overcome some of the difficulties they face. One other last point challenge that we face has to do with non-compliance to isolation and quarantine measures. So some of the patients, if you keep them in self-isolation, they tend not to stay at home. And sometimes we will have to get people to come in to enforce their staying or move them into isolation centers. And there is one major challenge, because then that would increase the risk of the patients mixing up with the general population and then causing other infections among the population. Now, the way forward. I think the way forward for us is continuous public education, that we need to emphasize the fact that COVID-19 is real. I mean, there are patients who have corona infection, and so then there's a need for everyone to prevent himself or herself from getting infected. And then the promotion of the use of mask, hand hygiene, and then social distancing. I think that there's also the need for continuous training of professionals to be able to get involved in testing and treating of cases. The enhanced surveillance, it will, from my presentation, you realize that the enhanced surveillance that was instituted by the government, the Ministry of Health, and the Ghana Health Service had yielded great results. And so we would encourage that there should be more enhanced surveillance and then increased testing, decentralization of the testing centers so that more people can be tested for us to be able to detect cases. And then provision of more isolation and treatment centers. The lack of adequate isolation and treatment centers is what is forcing some of us to keep patients at home, because then the isolation centers are also not available. So some of them have to be home to receive treatment or in self-isolation. And the global challenge, which is the availability of PPEs, that should also be made available for all frontliners and all people who are involved in hospital care. Thank you very much for your attention.
Thank you very much. That was a really very comprehensive view on what's happening in Ghana. Appreciate that, Kwame. Um, I have one or two questions. I don't see too many questions on our group. So if you have any group, from the uh, participants, if you have anything to a question, Kwame, just go ahead. We've got one person, Bulozo Mononge, who was willing to share a little bit of his country's input, but perhaps we can go through first any questions for Kwame. Kwame, I have one or two questions I thought I'd just clarify from you. You said that routine surveillance has produced some results, about 2.6% positive rates. Is this basically in your normal primary care setting? Is it in the hospital setting? Where is that routine surveillance done? How do you actually manage it? I imagine the extra sort of enhanced surveillance in the community is sort of going out in the community. And then I think your travel pickup rate is happening with travelers. Do you want to tell us what that means exactly on the ground?
Yes, so the
Maybe when you
routine,
go through that, yes.
good. The routine surveillance has to do with both, I mean, all the stages. So at the primary care setting, at the hospital setting, places where samples are taken or patients are admitted. And then
Right.
we also have hotlines that have been made available to the community. So they call, and then once they call, the team goes to take their samples. And some of the team members are disease control officers who go in to take the samples and then send the samples to the testing centers for
Right.
it to be done. So that's what we define as the routine surveillance.
Right. And what is enhanced contact tracing? Is that sort of a population-based approach, going through
Yes,
various parts of the population, sort of house to house screening and then testing?
exactly. And also,
Right.
there are some areas that have been identified as hotspot areas. So
Right.
those hotspot areas, they are the disease control officers or the testing officers are made to go into those communities. They knock on doors and offer screening for all the people within that population. So that's the enhanced contact tracing. And once a case is also picked within an area, within a geographical area, some of the houses within that geographical area are all earmarked. So they go into that community and then test all of them.
Right. So, if you were to look at it, how has the sort of progression of the disease, sort of, how has it progressed in the country? Is it still got a very strong link to the sort of travelers, or is it kind of spread throughout the country? When I look at, you've got 115 cases, mostly from traveling, I imagine the mandatory quarantine versus routine surveillance, which means that it's sort of come through the door of some sort of service somewhere. And is it kind of disseminated in the community and not any longer related to travelers?
There's some community spread, but it's not as widespread. And that was the reason
Okay,
that the government lifted the lockdown.
right.
I mean, from the analysis, we realized that
Yes,
it's more from travelers and
yes,
there's very little community spread.
right. Well, clearly, the community spread has been limited, and you'll have been very active in contract tracing in that sort of community chase up, where you've picked up a lot of cases. Although the yield has been good, low, but I think that's the largest amount of it. So that's been quite impressive, and I think that's what's leading to your cases. So the trajectory in the country, is it new cases are declining, new positives are declining on a day-to-day basis, and it'd be nice to see that chart, but that's an interesting proposal. I'm really glad because we all are walking around fearful of the consequences of it going wild in our countries. So well done to Ghana.
Right. Thank you.
I think they were. I don't see any other questions. I have a couple of others. If you have questions, feel free to stick up your question. I see one other question's popped up. Kezia asked, is COVID-19 still mostly in the two urban areas? I think that's one question. Maybe you can answer that. So is the cases you're finding look kind of limited to those areas, or is there some areas that it's spread out to rural or other cities or towns?
Well, thank you, Kezia. Yes, it's spread out beyond Kumasi and Accra. It has spread out to the eastern region. So people are familiar with Ghana. The eastern part also has quite a number of cases there. And then the northern part of the country. Just that in the northern part of the country, what was detected initially were some of our brothers from Guinea who crossed border into the northern part.
Right.
So 10 Guineans came into Ghana at a time, and when all of them were tested, they tested positive.
Wow.
So that contributed to the detection of cases in the northern part. So it's mainly in the northern part of the country, in Ashanti region, where Kumasi, where I am, and then Accra. But Accra is the highest.
Right.
So Accra, and then but in the other region called the Volta region, there are 9 cases that have been detected so far. So
Right.
for the villages and then the lower towns, it's not prevalent at all. It's more in Accra and Kumasi.
Okay.
Yes,
And
that's where
those
we have.
cases you just mentioned seem to be related to sort of border issues. Somehow they've crossed over.
Exactly.
And that's how
Border
you
issues.
found it. So have you all actually locked down borders? Are you very rigorous about people coming in now? How are you all
Yes,
managing travel?
yes, and they are doing surveillance at the borders, testing people, screening them for COVID-19. So that's very much enhanced at the borders.
Right.
Yes.
Okay, but one of the problems I have is the question of how do we go post-COVID? Border crossings are going to have to be really strongly managed. I used to think when we had in South Africa just temperature checks at the airport, I thought, no, this is not enough. People are asymptomatic, they cross over, and then the virus spreads. So are you all not allowing people in, or if you'll allow them in, are they requiring some sort of testing that they've done, or are you simply quarantining them for 14 days, or testing them and then deciding if they're negative to then, how are you managing that? I mean, whether it's flying in or at the border.
Yes, I know there are strict measures. In terms of the details, I would not
Not too sure.
claim to be, yes, an expert
Okay.
in that. But I know it's become more stringent for people to come in, and even for flights to come in unless it's essential items. But in terms of the details at the borders, I'll not be able to speak
Not a
to that.
problem. No,
Yeah.
thank you. Kezia asked another question, which I also find really interesting. It's similar to one I'd like to ask. How have the people in Ghana responded to COVID-19? Are there competing beliefs, social cultural practices that either enhance or impede screening, testing, and care for COVID?
Yeah, I
Because
think
you
that
mentioned
yeah,
stigmatization, and I was
yeah.
quite curious as what is the stigma around? But I think this question is, how are people responding to it? What's going on in their mind about this disease?
Yeah, that's a very good question. So I think we've gone through some phases. There was a
Yeah.
feeling of, okay, well, when there was Ebola outbreak, it was all over, but Ghana was not, we never detected a case. So initially, when everybody heard of coronavirus in China and coming to the extent that a case was detected in Burkina Faso, was detected in Togo, was detected in La Côte d'Ivoire, who are our neighbors, and Ghana had not detected any case, and everybody was still kind of hopeful that it will not get to us until it hit us. Then all of a sudden, everybody came to the realization that this thing is real. Then the lockdown also came in. So for the 3-week period, I think that the whole nation then came to the realization that this thing is real, and everybody was very careful. Most people were not coming out; they were keeping to themselves. Even though there were a few people who still flouted the partial lockdown regulation, they were going out and all that. But generally, people kept to their homes. And then the lockdown was lifted on Monday, and now it's as if the whole nation has been liberated, and majority of people seem to have forgotten all about it. So I think that's been the mood. But in terms of the myths and all that surrounding it, yes, in Africa and Ghana, people are really faith-based. So we've had a few of the faith-based organizations or some of the pastors coming out with some directives for their followers to do in order to prevent them from getting a COVID-19 infection. And then I just saw a patient on our ward whose family decided to use some herbal concoctions to prune themselves from getting the COVID-19 infection. So they prepared some herbal medications, boiled them, some of them drank them, and one of them turned out to have G6PD full defect. So has come in with jaundice, hemolysis, acute liver failure, and we are trying to get her out of it. So generally, there's still the need for us to educate our populace on the fact that COVID-19 is real. Some prominent people in Ghana have died as a result of that. The fact that it wouldn't take just taking herbal preparation to prevent you from getting the infection. It wouldn't take maybe doing a spiritual act to prevent you from getting the infection, but then sticking to the basic things that we advise: social distancing, wearing of masks, hand hygiene, cough etiquette. Those are the key issues. And I think it's an ongoing exercise that we all have a role to play in terms of education and sensitizing people.
Good, good. You mentioned stigmatization. What is the stigma around it? I think you mentioned it at an issue that, yeah.
Yeah, the stigma around it is not like the HIV stigma where we're thinking about, maybe some people think about infidelity or sexual acts causing it. But the stigma around it is in terms of you are the odd one out. The feeling of you being the odd one out. Because much as we recorded 1,100 cases, it's still not as pervasive or prevalent in Ghana as other countries. So if within a household you are the only one who has it, then you are seen as the odd one out. Or the person who gets it also has a self-stigma that, why me? Why, what did I do wrong? That kind of feeling. And that's what causes the stigma.
Okay. Buluzi, perhaps you'd like to share a little bit of what's going on in your country. I don't see any other questions. Thank you very much, Kwame. I think you'll hang around. Maybe you can still add some comments as well. I'm going to try to get Buluzi to join us and speak. Buluzi, go ahead. Do you want to share a little bit of where you're from and give us a bit of an insight into what's happening in your area, your part of the world? Buluzi, can you unmute yourself if you can, and you can just talk?
Okay.
You're able to talk. Hi, Buluzi.
Hi. Hi to everyone. I'm very happy to join this group and to share our experience.
Good.
Firstly, I'm Dr. Buluzi Jules from DRC. I'm a resident Université Protestante Congo in Kinshasa, but we are based in Goma at Hill Africa Tertiary Hospital. Our experience is that in Goma we had 3 cases of Ebola, but only in the town of Goma. In all the province in Nakivu, we had 5 cases. But now, all cases of Goma was healed, and we are 0 case. How do we proceed to heal all those cases? Firstly, I have to share when our country, DRC, was declared that the first case, our president imposed all measure of restriction and closed the borders around DRC. And here in Goma, the first case was declared in March. I think if I remember very good, it was 2026 when the first case was found in Goma, and it was a foreigner who were from Nigeria, and here Kigali, and Goma. He passed the last moment of when borders were closed. And the first case was diagnosed here in our hospital. But what allow us to limit all those cases? Firstly, Goma was in the last days of Ebola epidemic, and some measure of Ebola to fight Ebola was still taken by our team. And we started with our team with some measure of COVID to have a mask, some EPs, to our team. And all those measures was taken, was used at that night. That is why all contact of that first case became negative after test. When we received that patient, we inform immediately the provincial level, and the provincial level make an alert to all those hospitals. But when that patient left our hospital, he go at another one, and he was identified as the case of Hill Africa. And then after that situation, the province level, the riposte team of COVID-19 start now to look for that person, and they put the hand to that one and start to examine and send the sample to Kinshasa for test. And in a few days, that the answer, the test became positive, but before that, the result, that patient was putting in isolation. And those measures taken by our president, and here in the province, the governor took some measure to isolate the town of Goma. And then when he isolate the town Goma, he make restriction for movement of people. It means that in a bus, which took lastly 18%, restrict to that bus only 8% with distanciation of 1 meter, and wearing the mask. And all the population start to practice those measures. Combine those measures and all measures applied in all hospitals, all structures, medical structures, all physicians help our town to fight Ebola, Corona, and to heal very well all those cases which was found in Goma. And now we can say with conviction that we succeed to treat all those 3 cases found in Goma. For those 2 cases found out of Goma, but in the North province, there are 1 person healed, but we rest with 1 case only. And we hope that that only case who is in isolation will be healed in a few days, and we will be able to say that measures of isolation of virus cases was a successful followed. That is our experience. Secondly, in Hill Africa, which help Hill Africa to fight Ebola. It's because it's a teaching hospital, and we have many family physician residents who receive cases at the emergency unit with our coaching, our specialist in emergencies care, Dr. Muller. We are in front line as a family physician resident, front line fighting coronavirus. And we use all knowledge, all skills learned as a resident to fight, which is a good information for our hospital, using residents in family medicine and primary health care. And we are working as usual, treating patients without discrimination. And we hope that if everyone can follow our habit, it can be a success for our country and in the world. That is our experience, the experience that I want to share and that I share now with all persons who are here and all the world. And I think it can help those other one to fight COVID-19.
Well, thank you very much. In fact, I appreciate that insight, and it would really be good if we can begin to get others who are on this call who could share, even in the same countries, to share a little bit of the insight. So I want to come back to this question. Although there's a question that's for Kwame, but we'll just come to that. But I just want to share that it really is important that we look at exactly what are we doing in the front line as family physicians. So where are we placed and where exactly are we making that difference? Buleza, do you mind sharing with us a little bit of insight as to where you are functioning within your healthcare system and how you are finding yourself being able to make the difference? Do you mind just sharing that? I think it was very good insight into your country's situation. I'm just going to quickly pull up some data from the website, which I use. I look at quite frequently, is this Corona African Arguments coronavirus tracker. And it gives a kind of latest today. You can see that they're really small amounts. In fact, DRC is relatively small. I looked at them having 377 cases so far. And as you mentioned, it is relatively limited, mostly focused around travelers that are coming through. And I think from what you described, fairly well limited and in control. Where is your, Buleza, and maybe also Kwame, you can share, where are you working and where are family physicians working and what's it like? Maybe even your own experience. What are you doing that's making the difference?
As a family physician, future family physician,
yeah.
I'm working at Hill Africa Tertiary Hospital. It's located at east of DRC. We share a border with Rwanda and Uganda. Yeah. And as you ask, what the difference we make? We are family physician, future family physician, and we know how to speak, how to inform people, how to share information. Yeah, that is a big difference with which we use to ask that patient how what is the problem, and to make a good information about where he is from. I informed that patient, which was the first case here in Goma, is not a normally patient, because He has no fever, he has not fever, and he had not coughing. But according to the information that we know, how to interact with our patient, how to collect information, we identify that he was from Nigeria at the period where Nigeria have many cases. And he passed by Rwanda, Kigali. Kigali to arrive in Goma, he have to travel to Gisenyi, Gisenyi to enter in Goma. According to that situation and our knowledge as family physician, we firstly immediately diagnose, take him as a suspected case, an alert case. And here in Goma, at Hill Africa, which is the top hospital as teaching hospital, we are in front line as working at emergency room and outpatient department. We are the one who received those patients. That is a big difference with other hospital and other countries. As a future family physician, we are in front of line of at the emergency room and the outpatient department. With our skills of communication, we can be able to make differentiation and to see how to make a good diagnosis. In Congo, our health system is not more strong, but we are making effort with family medicine. We think that it can be able, if we are using at emergencies room and out department room, we can be a key to diagnose and to fight many epidemic situation and a pandemic situation. That is a big difference between Hill Africa Hospital, which is a tertiary hospital, and other hospital in the country.
Good. So just to capture it, I think you captured it as being, we are at the front line, being in emergency and outpatient department, which is interaction with people coming into with a volume of complaints. But in addition to the fact that where you are placed, you are at the front line. In addition, your ability to communicate better is making you much more effective in the community. In terms of picking up issues, having a better differential diagnosis, and listening better to pick up some of these issues. Perhaps I can ask this question, and I'm raising these because I want us all to realize there's a really good opportunity to share these stories in this manner, which demonstrates the principles of family medicine and how they are making a difference in your setting, as a story, as a way to describe what happens, how you feel you are making a difference. So thank you, Buleze, for coming on board. And I want to ask that Buleze, as well as Kwame, consider writing up a small blog. There's an article possibility. There was an email and a survey. So you can, whatever it is you do, if you can write it up, even in a half a page, we'd like to get that published in the next week or two, few days we're going along. So I urge you to think hard. I think you've given up some great ideas. One of the questions I have, and maybe you, Buleze, and Kwame can just speak to that question. How do you find yourself linking up to the community? And Kwame talked about, a sort of community-based program. Are you all very strongly linked to the community in that OPD hospital setting? How is the connection? How do you all try and make that work for yourself in terms of family medicine thinking? Buleze and then Kwame. Buleze?
The link that we have with the community is very normal and is very good. But the big problem that we are many times in the hospital. If we can leave that system of hospital and go, let those patients who came at the hospital for other pathologies, and we can have perhaps some days to go in the community to see those one who are not seeking, and who are there at the house waiting for something. It can be more good because as a family physician resident, family resident and a future family physician, our skills in communication can be more helpful for the community. And I think if we can, as we are not so many in Goma and in Congo, if we can continue with that training and we can we can change many things in our system in DRC, in our province, and even in our East African region. If we can go far from Goma and other countries, it can be more helpful because the hospital model is not more helpful. If we can go to the community model, it can be very more helpful. That is my, my answer. But our communication is more helpful for population and for patients uh, who came to see us at the hospital.
Well, that sounds interesting. So I hope, Ulize, you will try to write something up. I think and you can pass it to me and we can help you to beat it into shape. But I think it would really be sort of very good if we can put something together on your experience in Goma, in DRC. We can put a bit of a picture, but what you're doing and how you're doing it is a very important idea. Kwame, do you have
But
anything to
now,
share? Yes, go
excuse,
ahead, Gulaze.
I'm doing a case study on
Okay.
on that cases, and I don't know if I can share it with you to see
Please,
how we
please.
can publish it.
Good, wonderful. If we can shape it somehow and pull out of it exactly what you just said now, how our family medicine thinking is helping you to be more effective, those are the things. And even where it's challenged, like we talked about the community and what you'd like to do, important. Kwame, do you have anything to share? I mean, you already shared some elements, I mean, of you going out and having great difficulty. I'm not sure whether you have a strong link to that contact tracing, or is it just patient contact tracing? Sort of, is there a population approach that you're following, or is it just contacts from your patient set or patients that call you out? Do you mind just sharing how you have found yourself in Ghana becoming more effective because you are a family physician?
Yes, so thank you for that question. Even though I'm in the university hospital, we are within a municipality called the Oforikrom municipality. So within Oforikrom, they have the disease control officers. I think I kept making reference to them. So the disease control officers work within the municipal health directorate, and they work directly with us. So when we pick a case, even in the hospital, then we give them the contact of the person that we detected first in the hospital. We give them the address, the telephone number, and then any other person. And then disease control officers also go into the communities and then screen all the people who are contacts. There are a few times that we've even had to go into the house with them. And once we go there, the samples of those patients are taken. And when they pick a case, like they go in, they do the contact tracing, and then it's confirmed that the patient or the individual is positive, then we take over the management of the patient, and it goes on and on and on. So we are in close linkage with the disease control officers who work directly in the communities. And then talking about the role of family physicians in Ghana as well, I'm proud to say that two of family physicians who were trained from our college are even at the national level and are actively involved in taking care of patients at the national level, which is in Accra, where we have the epicenter of the COVID-19 in Ghana. And then even in our teaching hospital, in the districts and all that, where we have family physicians playing a role, in spite of COVID-19, we are making sure that primary care does not suffer. so that people who need to get refilled for their medications, hypertension, diabetes, people who get malaria, still get the chance to come into the hospitals and are taken care of. So all these are being done. Sometimes appointments are also being created, and numbers are being made available to patients so that they can call. Because in the midst of all this, we don't want primary care to suffer, and every other disease should also be given equal attention. So that's what we are also doing on our own as family physicians.
Yeah, wonderful. I think these stories need to be shared. I'll just share the I think a very interesting pro, you know thing that's happening. Um, PHCPI, which is the Primary Healthcare Performance Initiative, is an organization that's working very closely with the Bill and Melinda Gates Foundation and WHO. And they're quite keen to partner with Wonka and AfroPHC. They deal with primary care, but they're interested in collaborating, particularly around us doing a weekly blog or a weekly post with them on the question of what is going on at a primary care level and the sort of issues. And I think these stories, just exactly what you described, if we can start writing these up and sharing it with them, they'd really appreciate it. So I'm hoping that Kwame and Bulose will help share some ideas, share your thinking. So I'm waiting for something to come. So before we close, I have one more question, which maybe Kwame, you can answer this one. It's from Lubna Siddiq, who's asked, does the stigmatization that I think, Kwame, you were talking about involve healthcare workers currently working at COVID centers? So if you work at a COVID center, do you suffer some sort of stigma at a social level or a family level? Any ideas what's going on? Is that happening?
No, currently, no, we are not having suffering that
Yeah.
stigmatization.
Yeah.
And rather, what I've realized, it used to be with Ebola, but with COVID-19, I rather realized that a lot more health workers are eager to learn how to help. And especially they realize that there are PPEs available, they are trained how to wear and then remove them, use them well. A lot of health workers seem eager to learn, and they are rather not being stigmatized. Yes.
Yeah, I must confess, and perhaps in closing, I was quite impressed both with what you and Bulose said about the fact that people in Africa, in your communities, have responded and have a good sense of the difficulty and the challenge given Ebola. Ebola has made them more conscious, perhaps, of it and responded appropriately. Of course, as you said, sometimes when the lockdown's called off, then everybody goes back to normal, when in fact there ought to be a new normal with what you said, social distancing, masks, and hand washing. So with that, I think let's send the message out there that we need to be very, very wary of this condition. I want to say to all of you as family physicians, well done, and thank you all for participating. Kwame, thank you very much. It was a wonderful discussion. I really appreciated that. I see no more questions. Bulose, thank you very much for being our guest panelist. It was really appreciated, and I think we'd love to get other participants who are coming on board. Feel free, if you join the next time, to just share a few words. You don't need to do a lengthy presentation, but if you feel at all encouraged, please feel free next time to pick up your hand. So we'll continue this every week, and consider it an opportunity for you to come and share your story, and don't be afraid to pick up your hand and join the conversation. Kwame, thank you very much. To all of you, Bulose included, out there, take care, keep safe. Bye-bye, everyone.
Bye-bye.
We'll have our next webinar next week, Friday. Same time.
Thank you.
Bye-bye.
Thank you. Bye. Bye.